Good morning. Thank you, Professor Fikri, and thank you for the panel. I'm the chief CMO, not CEO. I don't want to be fired by the time I get back to the hospital that I was introduced as the CEO. But it's a pleasure to be here. And I'm going to really start from where the previous speaker finished. And my task is the art of winning, whether it's winning from the mechanical circulatory support. And as you see, I have changed the word of winning to winning because I think one of the issues with mechanical circulatory support, especially in the setting of STEMI, at least based on the most recent clinical trial, is that we don't have an early initiation of both de-escalation and winning. So sometimes, because of being a perfectionist, we leave the device too long, and when we leave the device too long, we start getting the complications. So this is a very brief outline of mainly discussing the MCS complication, MCS winning, with a reference to Emirate Cardiogenic Shock Initiative. So obviously, cardiogenic shock, 2/3 of all the shocks are cardiogenic shock, and most of those are related to acute myocardial infarction, and hence that's why we're talking about. I think that the question earlier, why the mortality rate of cardiogenic shock remains, I think is because we leave the shock to get into a stage of cardiometabolic shock. So whatever we do, we need to prevent the transition of a hemodynamic shock to a cardiometabolic shock, and I think that's where the biggest impact should be. This is the most recent clinical guidance from American College of Cardiology. It's a very good, concise review. While I do not agree with everything that is mentioned, I do not practice what is everything mentioned because I think some of the European guidelines are more forward-looking, but nonetheless, this is a very good review of the history of cardiogenic shock. Now, this is from that paper, and the paper really puts the framework in recognizing, rescuing, optimizing, stabilizing, and of course, the last item that I'm going to discuss is de-escalation and what is the exit strategy. I think we all can put the mechanical circulatory device, but I think that there is hesitancy in de-escalation and winning of the device, which I think leads to complications. Variety of mechanical circulatory support. I think the main comment that I would make here, and I think Professor Zimmer mentioned to it, is loading versus unloading devices. So I think that's the key. With all due respect to the data on ECMO and cardiogenic shock, to me, the concept of ECMO in acute STEMI cardiogenic shock is like the beta blocker in acute STEMI. We have data after data suggesting that the beta blockers don't work, and they still show up in the guidelines, or maybe it's still in class 2A, 2B. I think maybe we're going on the wrong path with regard to the type of the device that we employing in cardiogenic shock. This is an overview, and I put it because I'm going to concentrate on the danger shock trial. Obviously, we were all happy and high-fiving each other because of the danger shock showed significant benefit in reduction of the outcome. But what is we don't emphasize as much is what is the complication that came with the device and why did we have the rate of complication. The number needed to treat is 6, but the number to get a complication is 8. So the number of complications are still too high to make a significant impact. We have made an impact, but as the question earlier said, the complication rate still remain unacceptably high. And I'll come back to the dangers of danger shock trial as a part of the winning process. I think my task is really simple because it remains to the device winning and device selection. But I think the device winning, getting rid of the device and preventing the complication depends on how frequently we do monitoring in CCU and how actively we're pursuing both clinical, biochemical, and imaging criteria in order to have an early winning process. This comes from the same guidelines from the concise review from American College of Cardiology, and really the central element of the mechanical circulatory device and also weaning them is in multidisciplinary critical care support. And the questions are easy. Whatever the cause of the cardiogenic shock, have we taken care of that and taken care of it effectively? And most importantly, is there an ongoing end organ dysfunction? Is the lactate declining or rising? Is the kidney function and liver abnormalities rising or declining? And if yes, is the patient on a stable or declining vasopressor dose? To me, a patient who is on 3 vasopressor is not stable. Yes, stable because he has a good blood pressure, but that patient is not stable. And then, of course, there is no uniform weaning process that is being tested, that this weaning process is better than the weaning process. But the main message about the weaning is active monitoring of the patient and early weaning process. Because the data from the danger shock trial show that the longer the device was in, the higher was the complication, and hence the benefit was not as much as it could have been. Any discussion, any conversation, any presentation that I do, once I finish the presentation, I also ask ChatGPT, should I include anything else? So this, and I have, for lack of better term, I have called ChatGPT my uncle because he gives good advice. And this is what the ChatGPT has to tell me, is actually the weaning is really not starting the weaning process when it's time rather than when you have an acute complication, because once you have a complication, is the inflammatory process, and then it's too late to wean. And of course, is the most cautious approach to ECMO compared to intra-aortic balloon pump. Professor Schieffo mentioned to that, we cannot have an active management of cardiogenic shock patient without frequent clinical monitoring, number 1, number 2, regular biochemical monitoring, and number 3, echocardiographic active monitoring, all this in critical care unit or CCU, and paying attention to end organ function. The weaning process takes time and is not always successful. One thing is for sure, that the weaning process, if the weaning is not successful, those patients unfortunately do not do well. And even those patients that we are able to wean them, still there are parameters, patient's age and comorbidities that can impact the recovery of those patients. The complications of cardiogenic shock, obviously what unfortunately leads to the bad outcome. This is an overview of all the cardiogenic potential complication, and the most important is really, to me, neurologic dysfunction. Some of the reason that some clinical trials show benefit, one of the reason danger shock trial showed benefit because it excluded patients who had anoxic brain injury because it was too late for those. And I think paying attention to the system organ dysfunction in a stepwise manner is what can lead to improved outcome in these patients. Neurologic, cardiovascular, renal injury, obviously the vascular injury which was mentioned, and I will allude to that. One of the things which obviously, in the case of ECMO, I think we all know that it requires venting and the time of LV unloading. And whether we're putting the device before or after, the earlier we put the device and the earlier we initiate the unloading process, the outcome depends on how early this process takes place. This is a representation of, oops, that wasn't supposed to happen. This is a representative slide, I think Professor Zimmer mentioned, to the concept of ECMO or Impella, that even if you have an ECMO device, but if you start the unloading, you see how the pulmonary wedge pressure declines significantly when the unloading process starts. One of the most important complications, which unfortunately leads to adverse outcome and a spiral down, is the vascular complication. Because if you have a major bleeding, a lot of times this may force us to decide on what's antiplatelet therapy. We're either stuck to continuing antiplatelet therapy or stopping it or adjusting it. And of course, that what can lead to ischemic events on the top of acute hemorrhagic events. This is what I've mentioned earlier, is what I call the dangers of danger shock trial. The danger shock trial would have been even better if we would have been able, if the investigator had been able to avoid this complication. So that comes back to device. So device, not only the function, whether it's a loading or unloading device, but also what complication comes with the device. And I think that's where the field should be going. So this is an overview of new MCS in evolution assist devices. So one of the things that can significantly impact the outcome of the patient with cardiogenic shock, we know the unloading devices work, and a danger shock trial is a good example of that. So how can we replicate the benefits of the danger shock trial without replicating the dangers of the danger shock, which is the vascular complication? And the answer is the smaller devices. And of course, the number of smaller devices, including the Impella ECP, which is the newer iteration of the Impella devices, which at least the earlier clinical trial shows that have lower risk of vascular complication and most likely better benefit. So I think looking at 2026, 2030, we should be looking at a mechanical circulatory device, which is a microaxial flow process. It's a small device, so we're talking about 8 to 10 French, and the timing of the device, as was mentioned earlier, it needs to be I think that would be the winning process, or the winning process for improvement of outcome of cardiogenic shock.
Dr. Heidar, we have to wrap it up. We need to wrap it up to go to the next case.
Sure, this is my last slide, which is Emirate Cardiogenic Shock Initiative. I think this is, we have a paper which is in publication process. Thank you.
Excellent.